My name is Eloisa. I'm from Brazil, and I am an anesthesiologist at Marieta Condor-Burghausen, an hospital and maternity, and in Santa Catarina, Itajaí.
I don't think you're following.
I was invited to speak at this webinar because of an article that I published this year in the Brazilian Journal of Pain called Myofascial pain syndrome as a diagnosis of chronic abdominal pain. Today, I will be focusing on the diagnosis and treatment of myofascial pain itself. Okay, so first of all, myofascial pain syndrome's diagnosis is clinical. Its recognition basically derives from clinical history and physical examination findings. So its elaboration depends on professional training. Besides that, it's important to remember that this syndrome is one of the most common causes of pain and disability.
So they just.
Myofascial pain syndrome is a pain condition characterized by the presence of myofascial trigger points. The pain is generated by the muscle or muscle group, by the connective tissue, or in the fascia, not following a radicular or peripheral neuropathic pattern, and it may mimic visceral affection. A trigger point is a hyper-irritable spot in skeletal muscle that is associated with a hypersensitive palpable nodule in a taut band. This spot is painful on manual compression and can give rise to referred pain, referred tenderness, motor dysfunction, and autonomic phenomena. The induced factors of the emergency of trigger points can be dynamic overloads such as trauma or muscle activity itself, or even statics overload such as postural issues. And it can be perpetuated due to emotional, postural changes or to inappropriate movement execution. From a histological point of view, there are two classic findings, a contraction knot and the taut bands of the muscle. There is indeed a remarkable variability in the diagnosis criteria used in published research. And this is highly relevant as clinically, the diagnosis of trigger point is not based on just one criterion, but on a cluster of criteria. Therefore, here is the definition found in international consensus published in Pain Medicine Journal in the year of 2018, called Delphi Study, that defines the essential criteria as clustering of taut band, hypersensitive spot, and referred pain. We need to have at least two of these three criteria for a diagnosis of trigger point. However, members of the International Association for the Study of Pain and the American Academy of Pain Medicine consider that the essential diagnosis components of myofascial pain syndrome include hypersensitive spot, causing local pain that recreates symptoms when palpated. So, on clinical examination, we can observe a tight, palpable muscle band, which contains trigger point. When stimulated by palpation or needling, this trigger point generated pain that can be localized at or referred to previously standardized region. So the causes may even be in an area that's distant from the trigger point. We can note here that palpation represents the key process for identifying a trigger point during a diagnosis process. Additionally, we have secondary criteria that could also be used, such as local twitch response during the stimuli, jump sign, restricted range of motion, pain with muscle stretching, and pain with muscle contraction. After the diagnosis of myofascial pain syndrome, we must check if trigger points are active or latent. Classically, the main difference between active and latent trigger points is that active trigger points are related to spontaneous and continuous pain over time, while latent trigger points are painful only when stimulated. Although, according to the Delphi panel, active trigger points should be defined as trigger points that, upon stimulation, reproduce any symptom experienced by the patient, either partially or completely, whereby the symptoms is recognized as a familiar experience by the patient, even though it may not be present at the moment of the examination.
This one.
Whereas latent trigger points can be defined as trigger points that upon stimulation do not reproduce any symptom experienced by a subject, and the subject does not recognize the symptom as familiar. Now, I will start to speak about the disease control and the treatment of this syndrome. The first thing is that the etiological and inducing factors should be removed as much as possible, otherwise the curative effect may not be reached. As a basis for this purpose, there are healthy lifestyle habits, control of psychosocial and behavioral components that must be maintained in the long term for a better response. Given the interrelationship of chronic pain with biopsychosocial factors, directing awareness toward decreasing stress and anxiety can help alleviate myofascial pain. For the patient, short disease course and slight symptoms, we can use rehabilitation training, physical therapy, kinesiotherapy, muscle rehabilitation, and postural guidance. The purpose of physical rehabilitation therapy is to restore the function of muscle and fascia and to reduce the pain. Here we can see to the left a postural guidance published in 2010. And another alternative is kinesiology tape, this one. The treatment parameters of various forms of taping are still inconclusive. We can also use manipulation and stretch methods, which refers to the ones by which muscles are forced to move, like massages and frictions. The evidence for these manual therapies is moderate. On the other hand, patients with more intense symptoms might need to be treated with physical methods. A lot of physical methods exist, and they decrease muscle tension and inactivate trigger points. These methods are slow-acting and are not fully resolving in chronic cases of myofascial pain syndrome. And now I'm going to talk about just a few of those methods. The laser therapy has statistically significant difference if compared to placebo. Besides that, the polarized low-level laser therapy is more effective than just low-level laser therapy. The laser therapy improvements were greater than the that of the ultrasound and compression therapies. The ultrasound therapy is thought to stimulate the tissue beneath the skin surface using high-frequency waves. It causes an improvement in the outcome measures, and the continuous ultrasound may cause greater pain relief than post-ultrasound, but they didn't demonstrate significant effect on pain. About extracorporeal shockwave therapy, benefits were demonstrated at a systematic review, although it was considered an adjunct therapeutic method, not being useful alone. The transcutaneous electrical nerve stimulation demonstrated immediate benefits and has benefits among the non-invasive therapeutic modalities, but there are no sufficient data to determine the long-term effectiveness to this method. However, there is currently no evidence to support its use over trigger point injections or medications. At this point, transcutaneous electrical stimulation can be used as an adjuvant therapy to help alleviate myofascial pain, but should not be considered a monotherapy. The trigger point compression has been reported to be significantly hypoxic and possesses a lower pH, induces more ischemia, appearing to be counterproductive. Surprisingly, it has significant improvements after treatment.
Happens is mine, that little volume thing goes off.
So, summing it all up, there is strong evidence to support the use of laser, ultrasound, and extracorporeal shockwave therapies. Moderate evidence for electrical nerve stimulation and trigger point compression, and weak evidence for some other methods like galvanic stimulation, magnetic therapy, and instrument-assisted soft tissue mobilization. Medication can also be used for therapy on the syndrome. The symptomatic treatment based on symptom relief is important to improve the quality of life of patients with myofascial pain syndrome. We should prescribe oral medication at the lowest dose and the shortest course of treatment as possible.
It wasn't the person before you.
Non-steroidal anti-inflammatory drugs are the most commonly used drug for myofascial pain.
Then they go back
Multiple studies demonstrated strong evidence in support of anesthesia treating acute musculoskeletal disorders, so it is an appropriate initial treatment in both disorders. A diclofenac patch have statistically significant benefits with good evidence for the use, but as everyone already knows, long-term use should be considered with caution because of its side effects. There are some studies about the use of transdermal anesthetic that were congruent in showing that lidocaine patches had statistically significant increased pain thresholds and increase in general activity. Topical lidocaine has shown promise as a therapy for myofascial pain, and is especially appealing as it is not an oral systemic drug. So it was reported to have potential utility as a non-invasive pharmacological approach for managing trigger point with good evidence. Peripheral muscle relaxants, mainly tizanidine, decreases muscle spasticity. Studies supported a significant decrease in pain intensity and disability and improved sleep. It was also suggested that tizanidine should be considered a first-line agent for the treatment of myofascial pain. Finally, clonazepam is used too and causes rapid inhibitory neurotransmission. And in an open clinical trial, clonazepam was postulated to have an antinociceptive effect associated with myofascial pain syndrome, as it showed a statistically significant decrease in pain. A numerous set of medications are probably useful for myofascial pain, but we don't have good evidence for the use yet, and they are still under study. I will only talk about the main ones. And the first one will be tricyclic antidepressants. Although tricyclic antidepressant is widespread, there are limited studies specifically for the treatment of myofascial pain syndrome. Currently, there is no indication for the use of these medications in the treatment, but the growing body of evidence for their efficacy in chronic pain syndromes suggests an increased role in myofascial pain when conventional treatments fail. Anticonvulsants like gabapentin and pregabalin might be considered in treatment. And Cochrane literature review found that very few trials examined their effectiveness on acute pain, and most examined their use in chronic pain. To date, there are no randomized controlled trial of these anticonvulsants in the treatment of myofascial pain. About duloxetine. Duloxetine was recently found to be an evolving and possibly efficacious treatment for painful musculoskeletal conditions. As more research continues to be produced, this may prove to be especially useful in patients that also suffer from neuropathic pain or other mood disorders. Lastly, trazodone can frequently be used off-label for chronic pain, but it is still with no evidence for myofascial pain. As contraindicated medication in treating myofascial pain, we found the opioids. Although some limited studies demonstrate that weak opioids are moderately effective in treatment, most studies do not support their use. Furthermore, it is suggested that the use of opioids for the management of acute pain may actually be counterproductive to recovery. There are no studies investigating the efficacy of tramadol on myofascial pain, but it is used often for its multimodal analgesic effect and low abuse potential. Now, if a patient has a long course of disease, wide range of symptoms, and unsatisfactory curative effect after accepting various therapeutic methods, there is indication of trigger point inactivation, which can be done with dry needling, acupuncture, medication injection, and needling associated with physical methods. These methods produce mechanical disruption and stop the dysfunctional activity of the motor end plates, in addition to improve sleep and anxiety and stimulating the pain suppression system. Dry needling and acupuncture can be defined as the penetration of a needle through the skin without the inclusion of any medication. The difference between these techniques is that acupuncture therapy follows the traditional Chinese medicine, so it involves the insertion of needles in specific sites of the body located in the meridians. Dry needling corresponds to mechanical stimulus from the insertion of a needle in the muscle where the presence of a trigger point was detected. Both of these techniques stand out and produce positive and significant effects in immediate pain relief. Usually, when there is no relief of symptoms after at least 2 sessions, another diagnosis should be considered. They have been traditionally used like the fastest and most effective ways to inactivate trigger points and help alleviate the accompanying pain. Nonetheless, dry needling seems to produce a better response than the insertion of the same needle in an acupuncture point. These techniques act directly on the nerve fibers of painful sensation, stimulating the local activation of the A delta fibers and the inhibition of the C fibers that carry the local pain impulse, resulting in the relaxation of the tensile muscle band. The needling techniques can adhere to a variety of substance injections like local anesthetics, botulinum toxin A, tropizitron, and steroids. About the local anesthetics, the most common formulation of local anesthetics involves a mixture of lidocaine and bupivacaine. In a comparative study, dry needling was found to be as effective in injection of lidocaine, indicating that mechanical disruption by the needle may be the key therapeutic factor. The use of botulinum toxin demonstrates a statistically significant difference in pain intensity, duration, and reduction of trigger point. But as everything has its downside, these effects were only seen after 4 weeks. 2 studies compared botulinum toxin to bupivacaine and to lidocaine trigger point injections, and each treatment showed improvement with no significant difference between all these 3 drugs. The local injections of tropizitron at trigger point provide a statistically significant improvement in pain, and its effects began rapidly and lasted longer than those of local anesthetics. Although this may appear a promising treatment for myofascial pain, this yet requires further investigation. And finally, steroid injections are controversial and without clear rationale because little evidence exists to support underlying inflammatory pathophysiology on this syndrome. The needling can be accompanied by physical methods too, like electroacupuncture and fire needles. And electroacupuncture involves the application of needles and delivery of an electrocurrent. A pilot study demonstrated a significant reduction in pain levels immediately after treatment, and these effects were sustained for 2 weeks post-treatment. Electroacupuncture has shown some potential as a treatment method. However, there is still a lack of studies, so its use cannot be endorsed at this time. A fire needle refers to burning needle insertions, and the pain and functional impairment was significantly decrease in acupuncture plus fire needle, albeit not to a statistically significant extent. So to finish this webinar, it's important to reinforce that myofascial pain syndrome should be remembered as a possible diagnosis of pain, and treatment should be established in order to restructure the body's biomechanics and fully rehabilitate the patient. The potential for summated effects should also be considered in the use of a multimodal approach. Thanks for listening to this webinar. I really appreciate it to be part of this. And if you have any questions, I'll be available on this phone number and email. Thank you.
Thank you, Eloisa. It was an excellent presentation.